PCR for parvovirus B19 negative. In fact, HIV, hepatitis B and C screening was our negative. So in October, they did imaging studies, but only suggestive of infection cause. She had hepatomegaly, multiple rim enhancing hypodense lesion at the liver, suggestive of infection, also including the right kidney. Also, like lung lesion, which is likely infective in nature also, but no mediastinal or axillary lymphadenopathy and no splenomegaly. The cytogenetic come back as from the 6 cells analyzed, only they shows a normal cytogenetic, no cytogenetic abnormality. She initially was treated with cyclosporine since August, but withheld because of worsening liver function. Okay, now let's see the PBF. This time is PBF in September. At that time, she had a severe anemia with normal white cell count. However, the ANC is very low, 0.01 only, with absolute lymphocyte count of 6.12 and single digit platelet. So this is the peripheral blood film during the follow-up. Okay, if you notice that there is no neutrophils, okay, only lymphocyte, which is small to medium in size with condensed chromatin, mature looking lymphocyte, okay. No liquid erythroblastic picture or abnormal lymphoid seen. Okay, if you can appreciate the lymphocytes, they are fairly mature looking, small in size, condensed chromatin. Okay, because of this lymphocytosis, the clinician sent peripheral blood immunophenotyping. So this peripheral blood immunophenotyping was sent in September after 1 month of diagnosis of aplastic anemia, and she also was treated with cyclosporine. You can see from the site scatter versus CD45, only lymphocytes population are available. No monocytes, granulocytes, or erythroid population. And these lymphocytes are CD45 bright with low site scatter, meaning it is a matured lymphocyte. And if we analyze the B cells, they are CD45 bright, low site scatter with positive CD20 and 19, and preserve kappa lambda. You can see at the lower left box, kappa lambda, no restriction for the B lymphocyte, and the B lymphocytes are negative for CD5. But when we analyze the T cells, okay, these are the CD3 positive cells located at CD45 bright low site scatter. You notice that these cells are, if you see this box, CD4 versus CD8, the yellow population are actually CD4 and CD8 negative. Okay, predominantly CD4 and CD8 negative, CD56 negative, and they express CD5, CD38, and they are TCR gamma delta. Okay, TCR gamma delta. Okay, so you know that we are dealing with T cells population. So we proceed with the TLPD panel. Here again, the T lymphocytes are located at CD45 bright, low site scatter. They express CD2, CD7, CD26 and 28 heterogeneous, and they lack CD4 and CD8. So we are dealing with expanded population of CD3 positive double negative T cells, but no under expression of other T cell marker like CD2, CD5, CD7, only CD4 and CD8. Okay. So because of this, they repeat the bone marrow. They repeat bone marrow in October. The peripheral blood at that time shows similar finding with the PBF in September. Okay, these are the fragments. They are hypocellular fragments and hypocellular cell trail. Okay, this is another fragment, another fragment. Okay, another fragments. So generally the cell trails are hypocellular, comprised of lymphocytes, plasma cells, okay, lymphocytes and plasma cells. But the normal hemopoietic cells like granulocyte series, erythroids are markedly reduced. And from this bone marrow aspect also, the megakaryocytes were not seen. Okay, there is no megakaryocyte. So from this bone marrow aspirate, the findings are in keeping with aplastic anemia. Okay. We cannot assess the dysplastic changes because the normal hemopoietic cells are not there. So only lymphocytes and lymphoplasmacytic cells. So this is the pearl stain. Okay. Present stable iron. And the trifine biopsy. Okay, this is a very good trifine. You can see the cellularity, markedly hypocellular. This one is a second bone marrow in October. The first one in August, suggestive of aplastic anemia, then developed lymphocytosis. So this is the repeat bone marrow and trifine biopsy. So the findings are similar with the bone marrow at diagnosis. Okay, markedly hypocellular marrow. No megakaryocytes. Later we can confirm with CD61. If we analyze the cells inside, they are mainly lymphocytes. and plasma cells with some grains. So we also can appreciate that this hemosiderin-laden macrophage here, lymphocytes, plasma cells. Okay. So no obvious lymphoid aggregate or cluster of immature cells in the patient E. MPO, the myeloperoxidase stain markedly reduced. Okay. Meaning that the grand series are absent or markedly reduced. CD61, CD61 to confirm the presence of megakaryocyte, but in this case, no megakaryocytes seen. Okay. CD61 negative. So this is CD20. CD20 for the B cells. Scattered B cells. Okay. No lymphoid aggregate. For the T cells, usually normal bone marrow, there will be more T cells compared to B cells. So in this case, T cells are more compared to the B cells. They did not form any solid lymphoid aggregates or intravascular infiltration. The T cells are more compared to the B cells. CD2 is a T cell marker. The intensity of the staining is slightly weaker, but the number of the cells that are positive for CD2 are similar with the CD3. So meaning that there is no downregulation of CD2. CD5 is also T cell marker. Also, if you compare with the CD3, it is the same. And CD7. So there are no downregulation of CD2, CD5, CD7 in this case. And CD4. So if you look here, the CD4 can be tricky because of it is not specific for the T cells. Okay. But if you notice that the dark, this one, these are the CD4 positive T lymphocytes. They are present there. CD8. So CD8 are also present. So from this tree find, you can see that still the morphology still in favor aplastic anemia. Uh, the T cell population shows no lymphoid aggregate or nodule with still preserved CD4, CD8. And our TCR alpha beta stain was not working, and TCR gamma delta, we don't have that stain, unfortunately. But still, we are thinking of reactive double negative T cell in the peripheral blood in case of aplastic anemia. So aplastic anemia is a bone marrow failure disorder characterized by pancytopenia and hypocellular marrow in the absence of abnormal infiltrate or increased reticulate bone marrow. It's a rare hematological disorder associated with significant morbidity and mortality. Aplastic anemia is relatively common in Malaysia from the old paper. Usually observed in elderly group with second peak in the young adolescent group. Environmental factors such as drug, toxin, chemical may influence the incidence of aplastic anemia. Here in Sabah, we don't have published data, but we have a lot of aplastic anemia cases. And this case, we noticed that there are elevated double negative T cells. Some of the causes are autoimmune lymphoproliferative syndrome or malignancy, T cell large granular lymphocytes, leukemia. But in this case, the peripheral blood doesn't support presence of increased number of large granular lymphocyte, or it could be reactive gamma delta T lymphocytosis or hepatosplenic T cell lymphoma. In this case, this patient don't have splenomegaly, and we don't see intrasinusoidal infiltration. Or in autoimmune cases, SLE, ITP also can have elevated double negative T cells, infection, sepsis, medication, or treatment. So I got one paper here showing that in 11 pediatric cases, initially diagnosed as aplastic anemia, the number of, you can see on the right column, CD4, CD8 negative population are actually elevated in 9 of the cases. And interestingly, in 11 of the cases, the gamma delta population are more compared to alpha beta. And then, but the last case actually consistent with analysis of MDS because of the cytogenetic findings. So from this study in 2010, we can see that in aplastic anemia, there can be elevated double negative T population, and gamma delta T cell receptor are more common compared to alpha beta. And the diagnosis of autoimmune lymphoproliferative syndrome is not, I think, not fit with this case because this patient has no splenomegaly, lymphadenopathy. Okay, if this patient has splenomegaly, lymphadenopathy, maybe we might need to consider the ALPS. So currently the lymphocyte count for this patient coming down. This patient was stopped. The cyclosporine was stopped because of worsening liver function, transaminitis. So, is there any question?
Okay, Dr. Nasir, there's Dr. Faiz said in the chat box, I believe the HRP BEPO has gamma delta stain. Boleh try tanya this in dalam chat box lah. And there is also a question from Dr. Faiz. How to differentiate aplastic anemia and hypocellular marrow?
Okay, basically, when we want to say it is aplastic anemia, for me, I will look at the megakaryocytes. Okay, when megakaryocytes is proved to be absent by CD61 with diminished grand series, we can say it is aplastic. However, if we can still see these grand series, we can still see megakaryocytes, erythroid, then we have to look for evidence of dysplasia, and that's to exclude this hypoplastic MDS. And if this patient has a history of receiving any treatment, so patient can also has a hypocellular marrow without dysplasia. So the main thing is you have to do CD61 to prove that the mega is absent.
Okay, thank you, Dr. Na. Is there any questions? Anyone can share some thought or experiences or may give input regarding our topics today. And you can directly ask our speaker any question verbally.
Okay,
Or
there is
you
one
can post it
question.
in
Any
the-
suggestion when we have to screen for double negative T? Basically, for this patient, the problem is this patient suddenly developed lymphocytosis during follow-up. Initially, the lymphocyte count was normal, then become persistent lymphocytosis. So that's why we did peripheral blood IPT, and we found out that there is expanded double negative T. But I think we are not routinely screened for double negative T for aplastic anemia cases, unless if you have, for example, like my case lah, lymphocytosis. Usually, if you suspect autoimmune lymphoproliferative apa ni syndrome, when patient have splenomegaly, cytopenia, lymphadenopathy, then you need to do double negative T to diagnose LPS.
Okay, there's also a suggestion from Dr. Annie. I believe this condition may be underdiagnosed and master pathology student boleh consider this case or this diagnosis as a study.
Yeah, I think it's a good topic to do study. Especially in Sabah, we have a lot of aplastic anemia cases.
Mhm. Is there any other questions? So for those you can click the link for the feedback form, okay? I think if there's no further questions, we can end our session today. Thank you again to Dr. Ahmad and everyone. And on behalf of the organizing committee, we would like to thank the audience for attending our